Live. Just give me a second here. I think we are live. Yes. Hi, Dr. Armin. Welcome. This is Dr. Armin Schwarzbach. I'm excited to welcome you today. He is an MD, PhD from Augsburg, Germany, and a CEO of the lab Armin Labs, which tests for Lyme disease and co-infections. Thank you so much for joining me, Dr. Armin.
Thank you, Jenny. You're looking wonderful. It's a wonderful day here in Germany and in Canada.
Wonderful. Yes, I'm a naturopathic doctor on Vancouver Island, and I do quite a few tests through your lab, and I've learned a lot from you, Armin. It's great that you're here with me today.
It's a great honor to cooperate with you. Thank you.
Wonderful. Can you please describe your training in infectious diseases and what made you interested in specializing in lab testing of Lyme disease and other co-infections?
Yes, I'm a medical doctor, so this needs 6 years being a student in a university, and beneath that I studied pharmacy and little biochemistry and worked industrial companies like Aventis at that time. And I was really interested in the health sector, to help patients, to help people. And so I decided to do laboratory medicine because I could not see blood. That's an easy sentence to say. What was my challenge? In 1991, I worked 2 years infectious diseases in internal medicine. And that was the time H. pylori, Helicobacter pylori, came up, a very brand new thing to treat gut bacteria in the gut and people with gastritis, stomach problems, cancer. And we were very successful in that. And my education was internal medicine that time, nephrology, cardiology, gastroenterology, and oncology. And beneath that, I was also responsible for the infectious diseases department of a huge clinic. And I learned a lot about infections like malaria, parasites, Yersinia, Salmonella, hepatitis B, hepatitis C was non-A, non-B in that time. So I learned a lot about infectious diseases to diagnose and to treat. Chronic Lyme disease didn't exist that time in Germany. So I was convinced it didn't exist until 2005. I had an event. A patient came to me and asking for help. It was a multiple sclerosis patient with working disability, blindness, and sitting in a wheelchair, 40 years old. The spinal fluid was negative for neuroborreliosis and also no antibodies in the Western blots. And I did the first time in my life the LTT, it was named that time, and it was positive, a lymphocyte transformation test. I hope we talk later a little about that. And the test was positive, the antibody is negative. And the doctor called me. I worked for a huge laboratory group like Quest here in Germany that time. I was the CEO for that group with 400 employees, medical technical assistants. We say now it has 10,000 employees. But I was responsible also for microbiology and that infectious diseases. And I said, chronic Lyme, oh, maybe you could try that, doctor, treat with Rocephin. And the patient got cured from multiple sclerosis. I said, wow, what's that? It's an event in my life, yes. And that was the starting point. And I saw a lot of patients like that in the years after.
Wow. And so your lab testing in Germany, how is it different than North American Lyme disease testing?
Yes, it's a little different to the subspecies. We in Europe and maybe the rest of the world, we check more for Borrelia burgdorferi garinii, which makes more the neuroborreliosis, and we test more for Afzelii, which is also a different subspecies doing dominantly the acrodermatitis chronica atropicans. This is a skin problem when the skin is getting dry. And you or let me say North America, everybody believe that it's just the sensu stricto subspecies, which is responsible for joint arthritis. This is the history behind Willy Burgdorfer and Polly Murray in Connecticut, when they found young people with arthritis in early 80s. And they thought in America or Northern America for a while, they just have sensu stricto, the joint inflammation arthritis. But I think this is not the best way to believe just in one subspecies. We also have in Germany or whole Europe this subspecies with the joint arthritis, rheumatoid arthritis. So, but I'm convinced that people travel a lot around the world, and we got a lot of tick bites everywhere, South Africa, Australia, where we traveled in the past. And so what I've learned that also you cannot exclude in Northern America the other subspecies we are testing for. So you need a complete testing for all subspecies, Garenia, Afzelii, and sensu stricto, also in Canada as an example. It's not enough to do just a Western blot for sensu stricto. You need really the subspecies level to test for, otherwise you will miss that information.
So you're saying there's different species of Lyme disease, and we're just testing for one, but you're testing for multiple different kinds. They're the same. They're both all Lyme disease, but just different strains of it. Is that what you're saying?
Yes. It's a different antigenity, and the antigenity likes more different tissues. So Garenia likes more the nerve system. That does mean that's a general rule. It inflames your nerve system, neuropathy. That's the word, of fatigue or whatever, memory, concentration loss. So, but the sensu stricto inflames more the joints or the tendons. The Afzelii is more the skin dermatological problems. So, and now we know also that we have Miyamotoi and we have Barbariense, Lusitania. We have a lot of Spielmani, different other subspecies. We don't have tests for that.
Wow.
So we have still a lack of this subspecies, and we need also tests for that. But the more you test, the higher are the expenses for the health insurances or for the patients. The health insurances are not the friends of the Lyme patients, to say in a gentleman way. They don't accept chronic Lyme disease, so they don't accept payments. And the patients are not such rich ones. In Canada, you have a very prominent patient, Justin Bieber, with this infection. He surely can spend money on testings, but my experience is we need cheap testings, and I try to reduce the cost to do more testings for cheaper price on a very high quality level.
So you're saying in North America, they're only testing for one subspecies, like the medical system, and it's the joint arthralgia one that they're testing for?
Yes, if you would send to Quest or LabCorp, they all are fixed on this sensu stricto subspecies. There are some other laboratories which are more open-minded to that, but nevertheless, the experience to the 3 subspecies is bigger in Europe for sure, because we came traditionally from Garenia and Afzelii, so we have the best testings for that.
Interesting. So tell me more about what are the symptoms of Lyme disease, and why is it important to test for all of the co-infections along with Lyme disease?
Yes, what are the main symptoms? The tick is like a parasite or like a vampire, needs your blood, sucks your blood, also from animals, dogs. And after that, maybe you don't get any symptoms. You're symptom-free, but it could happen that there's a transmission of Borrelia burgdorferi, it's a spirochete, and the spirochete can move everywhere in your body. It's named bull's-eye rashes, we say in Germany, erythema migrans. So that means that it's a migrant pain, it's a moving pain. You could have pain in the elbow, carpal tunnel pain, you could have pain in your fingers, in your knee, you could have sensitivity, burning hands, burning feet, neck pain, you could also have headache on one side. Very interesting to mention in an anamnesis. I know you are doing a really good anamnesis for Lyme patients and co-infected patients, to find a correlation with an event, some event in your life where something is coming into your body, and after that you got sick. you got sick with chronic fatigue, or nearly all Lyme patients have fatigue. So fatigue is such an unspecific syndrome, but all co-infected patients are fatigued. So you cannot differentiate by the fatigue. Is it now Lyme disease or is it a co-infection? Not everybody has a co-infection. We test a lot of ticks now. In my area, my region around Munich, I find now 3 different pathogens, 3 different infections, co-infections, and Lyme disease in one tick. So I tested one tick for Meier-Motor, Rickettsia, and Borrelia burgdorferi here in Germany. The other tick was tested for Bartonella, Babesia, and Borrelia miyamotoi as an example. The other tick, I just find Rickettsia in it. What does it mean? Is Rickettsia now a co-infection, or is Borrelia a co-infection of Rickettsia? I think the word co-infection, which was branded by an IELTS doctor, IELTS is an international organization in America, was not correct to say it's a co-infection. That sounds like, oh wow, it's a baby, it's not so a huge problem for the patient. I would say more, what is the main infection? What is the dominating infection? And this I can tell you by the lab test findings. I do this interferon gamma release assays. It's a Th1 test system. And then I can tell you, oh, patient, it is not Lyme disease, it's a Rickettsia infection. Never heard about rickettsiosis. What's that? Yeah, you have muscle pain, you have muscle weakness, you have carditis, you have heart issues, you have fatigue, whatever. Maybe I find Bartonella. Bartonella, what is it? Bartonellosis. You have a cat patient, you had a cat scratching you. Oh yeah, and from at times it scratched me. Maybe you have some stria, some stretch marks on your body. Oh wow, yeah, we see that. So it's a really complicated thing. And what I can tell you from my perspective, my laboratory, I do thousands of tests every week. I would say everybody has a multiple infection. It's not just Lyme disease, or maybe it's not Lyme disease. And sometimes I have really problems to bring patients away. Patient, you don't have Lyme disease. You have a virus infection. You have a co-infection. You have a parasite. You have yeast and mold, or you have an enterobacteria, like Yersinia, Campylobacter, Salmonella. Oh, nobody told me that. So the whole story is really complex. It's a profile. We are profilers, like a criminal story. We need to find out as a laboratory which pathogen is active in which patient. And to screen, maybe the last sentence to that, to screen test is not good. It is expensive and it brings a lot of money in panel testing. I avoid every time panel testing. This is a money-making strategy. Panels are not good. You need to select the test. So I developed a co-infection checklist, and the co-infection checklist you can download from website, costs nothing, and it tells you the direction. And then you test just for the main infection. Panel is really not good. It's for laboratories good, but for patients, it's a loss of money. And my motto, do more money into therapies, not into labs.
Mm-hmm. So interesting. And it's interesting that ticks are not just carrying just Lyme. And a lot of people think, oh, I have all these symptoms of Lyme disease, and they fill in all the boxes for joint pain and anxiety and other things, but it turns out they have some other infection that they never thought of, and the lab will show which one it is, and then we know the direction of how to treat. So I think it's important to test to know. Just because you have symptoms of Lyme disease does not mean it's Lyme disease. Right? It could be something else or a multiple of things.
But you need a good doctor. You need a good therapist. The test selection should be done by the therapist, not the laboratory. You understand? So
yes.
And you do the specificity. You do the sensitivity. It's named the clinical specificity, the clinical sensitivity. We have a laboratory test sensitivity, laboratory test specificity, which is adapted to study design groups where the test producers, the certified test producers, need to develop that group. But what you do what is the predictive value of a result? The therapists are the key. But what happened? The patients, they think they are therapists, they know more than therapists, sometimes they know for sure, and they do the clinical sensitivity and specificity, and I can tell you they lose a lot of money by that way. I know that it's not their failure. They cannot change that because the chronic infections are not accepted in the medical world. This is a problem.
Yes, it's important definitely to consult with a professional to get proper guidance through all this. A professional doctor, naturopathic doctor, somebody who specializes in Lyme disease treatment. So tell me, what are the symptoms of Lyme disease? And sorry, we already asked you that. How do viruses play a role in chronic fatigue? And why is it important to also test for viruses as well? I've found viruses be sometimes the culprit in some patients, not Lyme disease.
Okay, let us talk about COVID-19 in this time. And you know, COVID-19 is a chronic fatigue virus, also a neurovirulent virus. And a lot of people with corona, they have chronic fatigue or fatigue for a while, 2-3 months or longer. We know that, but all viruses doing that. And my favorite in the chronic fatigue group is EBV, Epstein-Barr virus. You know that also Justin Bieber, he said, I'm suffering from Lyme disease, but I'm suffering also from EBV infection because Epstein-Barr virus cannot be treated with antibiotics. It's impossible to treat a virus with antibiotics. So you need a combination to treat a virus and bacteria. All co-infections, you name it, co-infections or all infections in a tick, they are bacteria and they need antibiotics as an example, or antibiotic herbs, or what you can do for that part. I'm not the specialist for that. On the other side, the viruses is really my experience, come together like Justin Bieber, EBV, CMV, cytomegalovirus, HHV6, HHV7, HHV8, human herpes virus. They all make a lot of fatigue. And they're the very traditional fatigued virus. But this is well known in the medicine that it's more accepted if you say, I have fatigue, the doctor, oh, you have Epstein-Barr virus infection. But if you would say I have Lyme disease and you have fatigue, the doctor will not accept this, you know. So this is a little problematic. So you could be happy if you have an active Epstein-Barr virus infection, not Lyme disease. You have better chances to be treated for a virus than for Lyme disease.
Interesting. Yeah, the Epstein-Barr virus, that's also the mononucleosis virus. And that's a common one, I guess, that we can see sometimes in chronic fatigue.
Yes, but not all are active. We can find out by a test if it's an active EBV or is it inactive, it's a sleeping, a snoring virus. Like the herpes virus of your lips. Some people have a snoring, a sleeping virus, and then it could be reactivated. You get bad problems of your lips, of your mouth, in your mouth, of your nerve system, neurological issues, or varicella zoster virus. They all can get reactivated. You live with them. You control them with your immune system. So with the COVID-19, we also have learned a weak immune system is not such a good thing if COVID-19 or influenza or EBV, also Borrelia, if it's coming, or rickettsia. The immune system plays the key on the one side. The infectivity of the pathogen of Lyme, of Borrelia, rickettsia, Yersinia, Campylobacter virus, parasite, it's on the other side. You have an invader, you have an aggressor, you have an enemy in your body. On the other side, you try to control that with your immune system. What happens if you have stress? What happens if you are older? If you have some bad illnesses before? If you have your cancer patients, you have a weak immune system. So what we need also, and I know you are a really good therapist in that part, you need to strengthen the immune system. But what is an antibiotic doing? Antibiotics are not good for your immune system. They suppress the cellular immune system, so more virus coming out. During my clinical time in the 90s, we never treated Epstein-Barr virus with antibiotics. We had some patients with a pneumonia, with a staphylococcus infection or a Klebsiella infection, and then we treated it additionally with antibiotics, so you could do a combination of virus treatment plus antibiotics. This is allowed. But if you just treat a bacteria and you forget about the virus, and I swear every patient I see with Lyme disease or suspected Lyme disease or co-infection, everybody has a virus. Everybody has an active virus infection. There's not any patient in the world I diagnose. So I say, please check for the viruses. It's so important for your therapy. Antibiotics are nice. I know the story with chlamydia, mycoplasma, Borrelia. By Eva Sapi, we cooperated very close together for years. So on the other side, I know now that we have a huge virus problem in the world.
Yes, very true. The role of the immune system is so important to support for these patients, right? Because so much when your immune system is down from one infection, then you're more prone to get other infections. Viruses.
And parasites, don't forget them, with the allergies and the
Yes.
food intolerances and the dogs and the cats, Ascarisum, Toxocaracanis, Strongyloides, and we eat up pork, we eat up parasites. Children are playing in the playground, you pick up your key from the ground and then you bring the eggs from a parasite into your mouth, you don't feel that. And parasital infections are really also important in the complexity of Lyme and other chronic infections.
So what's your vision for the future, Armin, for people suffering with Lyme disease or other co-infections who are not finding answers or diagnoses of their problems by the regular medical system?
Yeah, this is a huge challenge. I think we need still to struggle about Lyme disease, but in the end, we will see that we struggle also for other infections. We need to care for cocktails, we need to care for profiles, for cytokine profiles. We need also to care for different treatment options for different patients. We cannot say now we all take disulfiram or we all take an antibiotic, Dapsone, and we are all cured. So this is not the challenge. We have also genetics, epigenetics, with a hormonal axis. We have environmental medicine. We have the 5G discussion. We are poisoning ourselves by microplastics. We eat up aluminum in the planes. We eat up fish. We eat up really toxic stuff. We have bad teeth from our histories. So we need, I name it peeling the onion model. So we need to find out individualized what are the problems in which patient. So for sure, we cannot change genetics. We cannot change that. We cannot change how we look like. You with blonde hair, I'm with more gray hair now. So we cannot change our genetics. We look like that. We cannot change our fate from that side. We cannot alterate our DNA. That's impossible. But what we can do, we can strengthen our immune system. And we all live with our immune system. And what we are doing by our nutrition and all of the influence, the cell phones in our ears, the 5G here and there, playing just with PlayStation or so, this is not the way we should go in the future. I think the natural immunity is coming from the gut. I'm convinced about that. And the natural immunity needs sometimes support. And if you have an active virus infection or active bacterial infection, then you need also support, maybe by antibiotics, by virostatics is the other name, acyclovir, ganciclovir against DNA viruses, the herpes virus group, or the remdesivir. Now it's used for RNA viruses like COVID-19 infections. So what we need is individual profiles in individual patients, but this is really a challenge. The doctors, we need teams around that. One doctor cannot do that alone. We need interdisciplinary teams for that. But so long we don't accept chronic infections, nothing will happen. And we are blocked by universities politically because they say it's good to treat. EBV doesn't, everybody has EBV, everybody has herpes, everybody has Coxsackie virus, everybody has echovirus, everybody has Yersinia, but has or had or what it is, or is it, this is not answering my question. I want to know which infection is possible in which patient, and like you, I try to come from the differentials, from the anamnesis, from questions and answers about symptoms, and then you decide which tests you need to spare the money, not the panel testings, and then you spare money for therapies, and then you do individualized therapies like you are doing in the clinic, what I've heard.
So there needs to be more awareness, I think, with mainstream medicine that these infections exist and that they're causing people's symptoms, not just writing people off as psychiatric or it's all in your head because we can't find anything on our lab tests.
Yeah, in the end, the patient are psychiatric. They need the support because nobody's believing them. And if you have a depression, you need surely some support for your depression for a while because your serotonin level is low, but this is maybe by the infection. So long the infection is active, you have a serotonin deficiency in your brain, and so you need to support this. So it's not a shame to say, oh, I have panic attacks, I have depression. It's not, you need not to be ashamed to say to a doctor in the complexity of your other other symptoms. It's not just this point. You have also joint pain, you have cognitive dysfunction, you have your fatigue, you have the burning hand, burning feet, you have sensitivity problems, numbness, hypersensitivities. So this needs to be differentiated, and you're absolutely correct, to be accepted by the majority of the medical system.
Thank you so much, Armin, for being with me here today.
Thank you, Jenny. It was fantastic with you, and I hope that I could give you and your audience some input in this. And I know that you also fighting for that situation, like me. You're a clinician. I'm diagnostic doctor, and what I've seen in our discussion about some patients, I think it's a fruitful work to cooperate and not to say we don't talk about a patient situation from the laboratory doctor's point of views and from the clinician's point of view. That should be an interactive discussion for the benefit of the patient.
Yes, I benefit greatly from you as a mentor to me when I do my tests, just to help me with interpretation, because you've seen so many of these tests. So it really does help with my patient treatment plans, just to understand the tests and to know where to go with the testing and to figure out some answers for patients that are looking for answers.
Compliments back in the end. You're a really open-minded therapist. This is not the general rule, to say it that way.
Thank you so much, Armin, for being with me here today. Really appreciate it. Have a great day.
Enjoy your day. Thank you. Bye-bye.
Bye.
Bye-bye. Thank you. Bye-bye.